2 and 2 choices for a free informative booklet and DVD. Hey, Dr. Lederman, we're back.
We're back. It's Dr. Lederman, Radiosurgery Hour, taking your calls and talking about cases and news. So if you have questions, please feel free to call us. The next patient I want to talk about is an 80-year-old Hispanic woman. She came in just diagnosed 2 weeks ago with esophageal cancer. The esophagus is a tube between the mouth and the stomach. People often with esophageal cancer have early signs of blockage of the esophagus, so the food doesn't go down. The cancer can actually block or totally obstruct the esophagus. So in this case, this patient has had great difficulty eating. She's lost about 30 pounds over a very short period of time. She went to a hospital elsewhere. She had a biopsy and staging. She was found to have esophageal cancer with metastasis to the liver. She was offered standard treatment elsewhere, which would have been chemotherapy. She just didn't want chemotherapy. She didn't think it was in her interest. She was told it wouldn't offer her much extension of life. She came to us. Friends of hers, actually her cousin, was treated with a gastric cancer who had liver metastasis more than a year ago with radiosurgery and is in complete remission. So she has a favorable, personable knowledge of us, and she wishes to have our treatment for both the esophagus and for liver metastasis. So again, all our patients have all the options, and her choice is to proceed with radiosurgery, which is just 5 treatments to the esophagus, and then 5 to the liver, and then we'll restage her with cancer markers and PET scans. Our treatment is carried out in a stereotactic frame. It's outpatient. Patients walk in, get a treatment, 15 minutes later, get up and walk out the door and go shopping or go to lunch or go home, wherever they want, but not to sleep in a hospital. They have their treatment and go home where we think it's safer, better, and more warming for your heart, soul, and body to be home and not in a hospital. And interesting, we had a man who came in, 73 years old, who I treated for prostate cancer in 1992, 22 years ago this week. I treated him then with radiation and brachytherapy, similar to our program today. He's doing great. He works for the U.S. government at the airports, checks your passport when you come in, is doing well, and we're going to work him up, stage him up, get blood tests to make sure he stays in good shape for the rest of his life. There was an article about mammography, actually several articles about mammography this week. There's a controversy about mammography. There was a recent study from Canada suggesting mammography doesn't save lives. And now there's a new study from Norway that looked at all Norwegian women aged 50 to 79, evaluated between 1986 and 2006 at a national screening program. Scientists use this model to estimate breast cancer deaths in women who got mammograms as part of a government-funded program. About 76% of women who were offered a mammogram actually got it. The researchers estimated that there were 368 women given a chance to have mammogram to prevent one death, and that mammography has reduced the risk of dying from breast cancer by 28%. So Dr. Vars Latin of Norwegian Hospital said mammograms do provide benefit. Sometimes this screening is picking up lesions that are other than cancer, but there's a 28% reduction in death rate from breast cancer in women who are screened in Norway. There's some controversy, of course. In America, women are urged from age 40 on to have mammography, and in Western Europe, from age 50 to 70. So the American Cancer Society recommends mammograms annually from age 40 up. U.S. government-appointed task force recommended at age 50, and we all know women who were diagnosed with breast cancer before the age of 50. So you can make up your mind. We believe it's a safe method of saving tens of thousands of lives each year. In the New York Times, there was an article also about mammography, And there's a new little notice that's being put on the mammogram reports of many women. And this mammogram report says, your breast tissue is dense. Now, what does that mean if your breast tissue is dense? Well, it means that when you get a mammogram, some women have fatty breasts. Most women have actually a lot of fat in their breasts. And so when a mammogram is done, if there's a tumor or lesion, it's vivid in distinction to that fat. When one has a dense breast, there's a lot of connective tissue in the breast, and the breast appears whiter on the mammogram, and so it's more difficult to see lesions. So women will be getting notices, many women, not every woman, but women with dense breasts will be getting notices. If their breast is dense, they might want to seek other opinions or consultations. Mammograms miss half of breast cancers in women with dense tissue. About 40% of women who have mammograms have dense tissues. Women from Hawaii to California, New York, New Jersey are receiving letters about breast densities. Why? Because of a patient, Nancy Capello, a 61-year-old woman from Connecticut, whose cancer had spread to her lymph nodes by the time it was diagnosed 10 years ago, even though she had normal mammography. Her cancer was an inch in size when it became palpable. Her doctor said it was growing for 4 or 5 years before that time, and she had dense breast and had received reassurances that she was cancer-free. So there's a New York law, and there's actually laws in many states now, new laws, that if you have dense breasts, you need to be warned about it, you'll be notified about it, and you should speak to your doctor about other testing, for example, with ultrasound or MRI. So for all women, you should get your mammography. If you have dense breasts, you'll get this notice. Please give us a call or speak to your doctors about what to do next if you're not satisfied with routine mammography and if you have dense breasts. Of course, other technologies are available to you. Wanted to change the topic just a little bit now and talk about a 63-year-old Hispanic male, Spanish-speaking, who presented with flank pain in 2012. He went to a hospital in one of the boroughs of New York City and had a needle biopsy showing the cancer had already spread from the kidney to the lymph nodes. At that same hospital, he had a nephrectomy, which is removal of the kidney and the lymph node, which was cancerous. And then the cancer came back, and then over the last 4 treatment sessions, actually 4 cycles, 4 different types of chemos over the last year were given to this man at a famous cancer hospital. None of the experimental protocols or so-called clinical protocols worked. So he's deteriorating. He came to us to seek other opinions, and we told him our data. My son, Gil Lederman, who recently put together data for kidney cancer metastatic to the lung, revealed a 97% control rate. Control of cancer after radiosurgery means the cancer stops or shrinks or goes away. Ariel is presenting that information at a medical meeting, national medical meeting. Someone wrote me an email today, how do you evaluate your patients and how do you measure responses? Well, we have radiologists independent of us evaluate every patient. They document whether the cancer that we treated has grown, which would be a failure, has stopped or shrunk or gone away, which would be a success. And for metastatic kidney cancer to the lung, our current data shows a 97% control rate. This is non-invasive outpatient therapy. We've been at radiosurgery for more than 20 years. We have a long track record. Many patients we treat actually want to keep their kidney and not lose their kidney, and I showed that information to this 63-year-old man. So it's now up to him. He's had 4 clinical protocols in the last year. None have worked versus a treatment that has a more than 90% chance of control in the targeted area. Our treatment is non-invasive, generally well-tolerated. We don't accept every patient, and not every patient wishes to have our treatment, but obviously it's best to come in, sit down, and spend some time together and learn all the options, whether it's kidney cancer, breast, prostate, you name it. We are happy to talk about that cancer. And there's another news article this week saying that women with breast cancer are getting over-operated and under-evaluated with needle biopsy. This is from Reuters by Catherine Doyle, stating that most women should undergo needle biopsy for breast cancer diagnosis, but some surgeons want to do a more invasive procedure. Well, guess why? I think you can imagine guess why. The senior author of the study, Dr. Benjamin Smith from the University of Texas in Houston, said needle biopsy really is the standard of care. Having a 3 or 4 centimeter incision in the skin is going to hurt more and take longer to heal than just inserting a needle. The surgical approach is sometimes called open biopsy because it requires an incision to access the lump, or it's called an excisional biopsy. So authors have evaluated how often women were getting needle biopsies versus open biopsies and actually found a substantial number of women getting open biopsies rather than a less invasive, easier to perform, probably cheaper, needless to say, needle biopsy. So when women come to us with breast lumps, what do? Well, usually we'll get a mammogram or an ultrasound and put a little needle into that lump and give you an answer within a day or two about what it is. We've seen many, many women this year who have been delaying in getting treatment for fear. We'd advise you very strongly to come in, get worked up. If necessary, at worst, it's a little needle. The skin is numbed up, and you'll have an answer and a stage within a day or two. So it's certainly worth your while, and we're an advocate of doing the least surgery possible, especially if it's going to give you an equal or better quality of life. And really, that's what it's all about. If you can have an equal or better quality of life with less surgery, isn't that better? I suspect so. So we're going to pause. We're going to hear from our sponsor. Again, this is Dr. Lederman from Radiosurgery New York. We're located at 1384 Broadway at the corner of 38th and Broadway. We like to say we're not only super convenient, but I think we're super. We answer your phone calls. You can speak directly to the doctor. We'll send you information. If you need, we promise to see you within 1 business day. We have something called the Urgent Cancer Consultants, where if you need to see a doctor, an expert, within 1 business day, we promise that we'll stay longer, work harder to see you, to arrest your fears, or to treat you properly if there's a medical emergency. So again, this is Dr. Lederman. We'll be right back in a moment after this word from our sponsor.
Here's Dr. Gil Lederman, New York's only Harvard-trained, triple-board certified radiation cancer doctor. If chemosurgery or radiation isn't working or isn't tolerated, when cancer and its pain and symptoms aren't getting better, seek a fresh second opinion at Radiosurgery New York's Urgent Cancer Consultants for innovative, custom-tailored cancer treatment. See our experts within 1 business day because we know your time and your life are precious. Our goal is proper diagnosis and effective, non-invasive outpatient treatment. Decades of leadership, first in New York with brain radiosurgery, first in America with body radiosurgery for cancers of the brain, body, and prostate, all custom-tailored for you. Call 212-CHOICES, 212-CHOICES for a prompt appointment and free booklet DVD. Super convenient, 38th and Broadway, with most insurances, Medicare, Medicaid accepted. You're next at Radiosurgery New York. Just call 212-CHOICES, 212-CHOICES.
WOR, New York.
Welcome back to the Radiosurgery Hour. This is Rob Redstone here with Dr. Gil Lederman at the WOR studios in the heart of New York City. We're just a few steps from the Radiosurgery New York Cancer Treatment Center on Broadway and 38th Street. Dr. Lederman, the leading cancer expert, treats prostate cancer non-invasively. He was the first in New York with fractionated brain radiosurgery, and he's the first in America and in the Western Hemisphere with body radiosurgery. You can also call Dr. Lederman at 212-CHOICES for a free informative booklet and DVD. Hey, Dr. Lederman, we're back.
Hey, we're back. We have a special listener tonight, which we want to wish well. A person with a splenic marginal zone lymphoma undergoing treatment. We wish her excellent care, excellent results, and she should live to be 120. As the Jewish people say, Me'av Esrim. We had a special patient also who came in this week, a 55-year-old woman with 2 children. She presented with pressure and severe pain in the face in January 2013. A very interesting